Ramanarain. On to the question number 66. An 80 years old woman is brought to the emergency department due to diarrhea. The patient has advanced Alzheimer's dementia and is cared for by her daughter at home. Her daughter reports that the patient has had 6 to 8 non-bloody watery bowel movements a day for the past several days. The patient has had multiple hospitalization for similar symptoms in the past 6 months. In each case, evaluation was negative for infection and symptoms resolved within a few days. Home medication include Dunpazil and Memantine. The temperature is 37 degrees Celsius, blood pressure is 110 by 70 millimeters of mercury, and pulse is 104 per minute, and the respirations are 18 per minute. Physical examination shows dry mucous membranes. Heart and lung sounds are normal. The abdomen is soft and non-tender. The lab evaluation shows hypokalemia and metabolic alkalosis. C-reactive protein and fecal cal protein are unremarkable. The patient is hospitalized and intravenous fluids and potassium replacement are begun. Colonoscopy shows dark brown mucosal pigment in the proximal colon, but otherwise unremarkable. Which of the following is most appropriate next step in the management of the patient? Determine the fecal fat concentration, discontinue memantine, notify the adult protective services, order serum vasoactive intestinal polypeptide level, start the oral budesonide therapy. And the answer of choice is option Charlie, that is notify adult protective services. Educational objective of this question is stating that melanosis coli is an abnormal brown pigmentation of the colon due to excessive use of anthraquinone, sina laxatives. Factitious disorder imposed on other is characterized by causation of falsification of illness in an other person, typically a family member, to obtain psychological validation, or falsification of sick caregiver role. The victim must be protected by notifying the protective services. Here you can see the discussion is stating that the patient has had multiple hospitalization for diarrhea associated with dehydration, that is dry mucous membranes, and electrolyte abnormalities, for example hypokalemia and metabolic alkalosis. Colonoscopy shows melanosis coli, which suggests anthraquinone, for example sena, laxative abuse. Excessive use of the anthraquinones cause colonic epithelial damage and the release of brown pigments, that is lipofuscin, into the lamina propria that can be visualized on colonoscopy. It takes several months of abusing anthraquinones to develop the melanosis coli, and it disappears when the laxatives are discontinued. Because the patient has advanced dementia and is cared for primarily by her daughter, evidence of laxative abuse raises the possibility of factitious disorder imposed on an other, that is FDIA, that is Munchausen syndrome, something like that. FDIA is characterized by the induction or falsification of illness in an other person, typically a family member. As in factitious disorder imposed on self, illness in the factitious disorder imposed on an other are induced to obtain not a tangible benefit, for example the financial compensation, access to controlled substances, but psychological validation or falsification of sick or caregiver role. Children are most commonly the victim of FDIA, but the elderly patient may also be abused in this manner. The victim must be protected from further harm. In this case, the adult protective services should be notified. The choice alpha, that is determine the fecal fat concentration. This was not the option of choice because steatorrhea, that is increased fecal fat levels, occurs in the malabsorptive disorders such as pancreatic insufficiency and celiac disease. These patients' stool are not typical of steatorrhea. For example, greasy, foul smelling and malabsorptive disorders do not cause the melanosis coli. The choice beta, that is discontinue memantine. This is not the option of choice because although memantine can cause loose stools, it does not cause melanosis coli and is unlikely to result in this patient's diarrhea. The choice delta, that is order the serum vasoactive intestinal peptide level. This is not the option of choice because the VIPoma is a neuroendocrine tumor that causes a persistent secretory diarrhea. This patient's intermittent diarrhea is atypical for VIPoma, and melanosis coli would be unexpected. The choice eta, that is start the oral budesonide therapy. This is not the option of choice because inflammatory bowel disease, which can be treated by the glucocorticoid, for example the budesonide, presents with a diarrhea associated with the hematogasia, abdominal pain, and elevated inflammatory markers, for example the C-reactive protein and fecal calprotectin. It only rarely causes melanosis coli. The next question, number 67, is about a 26 years old woman comes to the office due to progressive tiredness. The patient has no known chronic medical condition and takes no medication. Her menstrual periods are regular and bleeding lasts 3 days. The patient does not use tobacco, alcohol, or illicit drugs. Examination shows no abnormalities. Complete blood count is as follows. The hemoglobin is low, that is 10.1 grams per deciliter. The mean corpuscular hemoglobin concentration MCHC is 32% of Hb per cell. Mean corpuscular volume is low, that is 70 micrometer cube. The platelets are 200,000 per millimeter cube. Leukocytes is 7500, out of which the neutrophils are just 58%. The lymphocytes are high, that is 35%. The monocytes are 5%. Eosinophils are 2%. Fecal occult blood test is negative. Iron therapy is initiated. When the patient returns 6 weeks later, her lab findings are unchanged. Which of the following is the most likely cause of the patient's condition? The answer options are option A, bone marrow aplasia, option B, bone marrow infiltration, circulating anti-red cell antibodies, cobalamin deficiency, erythropoietin deficiency, folic acid deficiency, or hemoglobin defect. And the answer of choice is okay. There are other options as well: hereditary red cell membrane defect, iron deficiency, red blood cell enzyme deficiency, or traumatic hemolysis. And the answer is option G, that is hemoglobin defect. Educational objective of this question states that the two most common causes of microcytic anemia are iron deficiency anemia and thalassemia, are differentiated by iron studies. Thalassemia is hemoglobin defect caused by alteration of more than equal to 1 of the globin subunits. Thalassemia minor is minimally symptomatic. Now let's see this table. This table is about iron deficiency anemia and thalassemias. Parameter. First we will talk about iron deficiency anemia, then alpha thalassemia minor and beta thalassemia minor. So the parameter in iron deficiency anemia, the mean corpuscular volume will be low. The RDW, that is RBC distribution width, something like that. It is basically the measure of the variation in the size of RBC from the smallest RBC to the largest RBC. The width between the sizes of these two RBCs is called as RDW. That will be increased. RBC's count will be decreased in the iron deficiency anemia. The peripheral smear will show microcytosis and hypochromia. Serum iron studies will show decreased iron and ferritin and increased total iron binding capacity. Response to iron supplementation will show increased hemoglobin, and hemoglobin electrophoresis will be normal. Now let's talk about alpha thalassemia minor. The mean corpuscular volume will be decreased. The RDW will be normal. RBC count will be normal. The peripheral smear will show target cells. Serum iron studies will show normal or increased and ferritin RBC turnover, normal or increased iron and RBC turnover. Response to iron supplementation will show no improvement. Then we have beta thalassemia minor. The mean corpuscular volume will be decreased. Then the RDW will be normal. RBC count will also be normal. The peripheral smear will be showing target cells. Serum iron studies will show normal or increased iron and ferritin RBC turnover, and response to iron supplementation will show no improvement. Hemoglobin electrophoresis in the beta thalassemia minor will show increased hemoglobin A2, while in the alpha thalassemia minor the hemoglobin electrophoresis will be normal. Now let's read the discussion. Yes, it is red cell distribution width. So they are saying that the two most common causes of microcytic anemia are iron deficiency anemia and thalassemia minor. Have similar laboratory, for example, the low mean corpuscular volume, low mean corpuscular hemoglobin concentration, and peripheral blood smear, for example, the target cell and hypochromia. Findings. Differentiation requires iron studies, but empiric iron supplementation is sometimes prescribed. Lack of improvement in the hemoglobin level within 4 weeks make the iron deficiency unlikely. Therefore, this patient likely has thalassemia, a genetic disorder with a hemoglobin defect. Then we have, hemoglobin A, the major form of the hemoglobin in the children and adults, contain 2 alpha globins and 2 beta globins. Transcription of 4 alpha globin and 2 beta globin genes is tightly regulated. For example, specific ratio of alpha beta globin production. In thalassemia, mutations or deletions to more than equal to 1 of these genes alter the ratio of alpha beta globin synthesis. Precipitation of excess unpaired globin genes result in the erythrocyte toxicity in the bone marrow, ineffective hematopoiesis, and bloodstream hemolysis. Thalassemia severity depends on the number of globin chains affected. Defects in one or two of the alpha globin chains, alpha thalassemia minima or minor, or one of the beta globin chains, that is beta thalassemia minor, often causes minimal symptoms. Thalassemia minor is associated with mild, moderate reductions in hematocrit more than 28% and low MCV 55 to 75 micrometer cube. The choice A and B, that is all the way over here. So there are a lot of choices to this question. Choice A was bone marrow aplasia and B was bone marrow infiltration. None of them were the options of choice because aplastic anemia, multipotent hematopoietic stem cell injury, and the bone marrow infiltration, for example, the myelofibrosis and metastatic cancer, are usually associated with pancytopenia and normocytic or macrocytic erythrocytosis. The choice C and K, that is circulating anti-red blood cell antibodies, and K was traumatic hemolysis. None of them were the option of choice because circulating antibodies to the erythrocyte membrane and the traumatic hemolysis, for example, the erythrocyte shearing on the artificial heart valves, can cause hemolytic anemia, usually associated with the normocytic anemia and sometimes manifestations of hyperbilirubinemia, for example, icterus. The choice D and F, which are cobalamin deficiency and folic acid deficiency, none of them are the option of choice because cobalamin and folate deficiency leads to macrocytic anemia and hypersegmented neutrophils. The choice eta, that is erythropoietin deficiency. This is not the option of choice because the erythropoietin deficiency, erythropoietin promotes the erythrocyte differentiation and maturation. Deficiency most commonly seen in the renal failure is associated with a normocytic anemia. The choice H, that is hereditary red blood cell membrane defect. This is not the option of choice because hereditary spherocytosis is associated with a hemolytic anemia due to erythrocyte membrane defect. Mean corpuscular volume is low, small erythrocyte size in the membrane, size from the membrane defect, but MCHC is elevated more than 36% hemoglobin percent due to the increased hemoglobin to cell membrane ratio. The choice J, that is red blood cell enzyme deficiency. This is not the option of choice because deficiency of erythrocyte glucose 6-phosphate dehydrogenase leads to oxidative injury and subsequent hemolytic anemia. MCV and MCHC are usually normal. The next question is about, question number 68 is about a 24 years old woman comes to the clinic after 3 weeks of heat intolerance and increased appetite. Despite increased caloric intake, she has lost weight. The patient's medical history is insignificant and she takes no prescription or over-the-counter medications. She does not use tobacco or illicit drugs and consumes alcohol only on rare occasions. The patient last menstrual period was 3 days ago. Okay, last LMP was 3 days ago and was unusually light. Temperature is 37.2 degrees Celsius, that is 99 degrees Fahrenheit. The blood pressure is 130/75 millimeters of mercury and pulse is 110 per minute and regular. Respiratory rate is 14 per minute. On examination, the thyroid gland is mildly enlarged, mobile and non-tender. The cranial nerve examination is normal, although there is mild lid lag. Okay, the laboratory results are as follows: the free T4 level is increased, T3 level is increased, and TSH level is decreased. Radioactive iodine uptake is less than 5%. Normally it should be 8% to 25%, but it is less than 5%. The thyroid gland is not visualized on thyroid scan. Which of the following is the most likely diagnosis of this patient? And options are Graves' disease, painless thyroiditis, stroma ovariae, subacute thyroiditis, or toxic nodular goiter, and the answer is option beta, that is painless thyroiditis. Educational objective of this question is painless thyroiditis, that is silent thyroiditis, is characterized by acute thyrotoxicosis with mild thyroid enlargement and suppressed TSH. Thyroid scintigraphy shows decreased radioiodine uptake. Now let's see this discussion table that is about thyroiditis. They are saying that chronic autoimmune thyroiditis or Hashimoto thyroiditis, clinical features are predominant hypothyroid features and there will be a diffuse goiter in Hashimoto thyroiditis, which is also called as chronic autoimmune thyroiditis. Diagnostic testing is by positive TPO antibody and variable radioiodine uptake. The next thing is about painless thyroiditis or silent thyroiditis. Variant of the chronic autoimmune thyroiditis, mild, brief hyperthyroid phase, small non-tender goiter and spontaneous recovery will be seen. There will be positive TPO antibody, low radioiodine uptake. Then the next is about subacute or decurvent thyroiditis, the only painful thyroiditis, likely post-viral inflammatory process. prominent fever and hyperthyroid symptoms, painful tender goiter will be there. Elevated ESR and C-reactive protein and low radioactive iodine will be there. Low radioactive iodine uptake. The next discussion is about this patient has painless thyroiditis, silent thyroiditis characterized by acute thyrotoxicosis with mild thyroid gland enlargement and suppressed TSH. Painless thyroiditis is an autoimmune disorder thought to be variant of Hashimoto thyroiditis, although the latter classically present with a chronic hypothyroidism. A similar disorder can also be seen within a year following the pregnancy, uh, but would be properly termed postpartum thyroiditis. The follicular inflammatory reaction is painless thyroiditis may occasionally lead to a persistent hypothyroid phase, but most patients recover normal thyroid function. Okay. Patients with hyperthyroidism and a suppressed TSH should undergo thyroid radioiodine scintigraphy to distinguish the painless thyroiditis from the Graves' disease. With painless thyroiditis, radioiodine uptake is decreased, suggesting the release of preformed thyroid hormone. Okay. In contrast, the Graves' disease causes the hyperthyroidism due to the increased synthesis of thyroid hormone. Radioactive iodine will be diffusely increased, and extrathyroidal manifestation, for example, exophthalmos, pretibial myxedema, are often present. Okay. The choice Charlie, that is all the way over here, that is stroma ovarii. This was not the option of choice because stroma ovarii is a very rare cause of thyrotoxicosis and is due to the production of thyroid hormone by an ovarian teratoma. It typically presents in the woman age over 50 and a pelvic mass, ascites, or abdominal pain. The thyroid gland is not enlarged in this condition. Is not enlarged with this condition. The choice delta, that is subacute thyroiditis. This is not the option of choice because subacute thyroiditis, granulomatous or decurvent thyroiditis, also causes hyperthyroidism with a suppressed TSH and decreased radioiodine uptake. However, it is associated with a painful tender goiter. The choice eta, that is toxic nodular goiter. This is not the option of choice because the nodular thyroid disease is a more common cause of hyperthyroidism in older individuals. A thyroid scan will show increased uptake in either a focal toxic adenoma or heterogeneous toxic multinodular goiter pattern. Then question number 69 is about a 64 years old non-diabetic man complains of cramping pain in his right thigh after walking 2 blocks. The pain goes away once he stops and rests for several minutes. He is an ex-smoker with 35 pack year history. On physical examination, the distal pulses are diminished on the right leg. His ankle brachial index is 0.98 on the left side and 0.75 on the right side. Which of the following is this patient most likely to suffer over the next 5 years? And the options are abdominal aortic aneurysm rupture, above knee amputation, below knee amputation, intracranial hemorrhage, or myocardial infarction. So the answer of this question is option eta, that is myocardial infarction. Educational objective of this question is cardiovascular disease is a major cause of morbidity and mortality in the patient with a peripheral artery disease or PAD. Patients with the PAD and intermittent claudication have an estimated 20% 5-year risk of non-fatal myocardial infarction and a stroke and a 15 to 30% risk of death due to cardiovascular causes. Only 1 to 2% patients with a peripheral artery disease progress to develop a critical limb ischemia with a risk of limb amputation. Now let's see the discussion. The patient's clinical presentation with the symptoms of intermittent claudication, diminished pulses, and abnormal less than 1 ankle brachial index is suggestive of the peripheral artery disease involving the right lower extremity. Multiple studies assessing the natural history of the patients with the peripheral artery disease have found intermittent claudication as a strong predictor of further risk of cardiovascular morbidity and mortality. Patients with a peripheral artery disease and intermittent claudication have an estimated 20% 5-year risk of non-fatal myocardial infarction and stroke and a 15 to 30% 5-year risk of death due to cardiovascular causes. I guess. Okay. Okay. Cardiovascular causes, the risk rises exponentially with the progression of peripheral artery disease, with an estimated 25% 1-year risk of cardiovascular mortality in the patient with a critical limb ischemia. The presence of peripheral artery disease is a coronary artery disease risk equivalent, and these patients should be managed with aggressive risk factor modification for the prevention of cardiovascular morbidity and mortality. The choice alpha, that is abdominal aortic aneurysm rupture. This is not the option of choice because the abdominal aortic aneurysm can be detected in approximately 10% of the patients with peripheral artery disease The risk of abdominal aortic aneurysm rupture is increased in the patient with a large aneurysm diameter that is more than 5.5 cm, aortic expansion rate more than 0.5 cm per year, male sex, and current ongoing smoking. The patient has no smoking or signs suggestive of abdominal aortic aneurysm and therefore is not at increased risk of rupture. The choice beta and Charlie, that is above knee amputation or below knee amputation, these were not the options of choice because the majority of the patients, that is 70 to 80% with intermittent claudications, continue to have stable claudication symptoms at 5 years. Approximately 10% to 20% of the patients progress to worsening claudications, and only 1 to 2% progress to develop critical limb ischemia with rest pain, non-healing ulcer, and tissue gangrene that may require limb amputation. The choice delta, that is intracranial hemorrhage, this is not the option of choice because the presence of peripheral artery disease is not associated with an increased risk of intracranial hemorrhage. The next question, number 70, they are asking about a 53 years old woman is brought to the emergency department after she collapsed suddenly while standing and lost consciousness for approximately 3 minutes. Okay, she recovered spontaneously. But was very weak and dyspneic. She also reports left-sided chest pain. She was she was no There was not tonic-clonic activity or incontinence. The patient was recently diagnosed with a colon cancer on routine colonoscopy and is scheduled to undergo surgical resection. Her only other medical problem is hypertension, but she has not been compliant with her medication. Her blood pressure is 86 by 50 millimeters of mercury, that is very low. Pulse is 120 per minute, very high and regular. Pulse oximetry shows 80% of the room air. She is diaphoretic and tachypneic. The jugular venous pressure is 13 centimeter of water. The lungs are clear to auscultation. Further workup in this patient would most likely show which of the following. Option A, acute mitral regurgitation, complete heart block, left middle branch block, mediastinal widening, pericardial tamponade, the right ventricular dysfunction, or tension pneumothorax. And the answer to this question is option F, that is right ventricular dysfunction. Educational objective of this question is stating that over here, the patients with a massive pulmonary embolism usually present with the signs of low arterial perfusion, for example, the hypotension, syncope, and acute dyspnea, pleuritic chest pain, and tachycardia. The thrombus increases the pulmonary vascular resistance and right ventricular pressure, causing the right ventricular hypokinesis and dilation and hypotension. The discussion is having a flow sheet diagram that is stating the pathophysiology of the massive pulmonary embolism. Massive pulmonary embolism will lead to right ventricular outflow obstruction and increased right ventricular pressure. That will lead to right ventricular hypokinesis, decreased right ventricular output, decreased left ventricular preload and cardiac output, decreased right ventricular oxygen supply. That will lead to right ventricular ischemia and infarction, ultimately right ventricular failure and shock. Also, the right ventricular outflow obstruction and increased right ventricular pressure will lead to right ventricular dilation. That can lead to increased right ventricular wall tension. That will lead to increased right ventricular oxygen demand, and that will also lead to right ventricular ischemia and infarction, and ultimately right ventricular failure and shock. The patient's underlying malignancy, for example, the prothrombotic state and acute presentation of dyspnea, chest pain, tachycardia, hypoxia, and clear lungs are highly suggestive of pulmonary embolism. The patient with acute massive pulmonary embolism can present with syncope and hemodynamic collapse. Examination can show an accentuated pulmonary component of the second heart sound and elevated central venous pressure, that is high jugular venous pressure. Acute massive pulmonary embolism in abrupt acute massive pulmonary embolism results in abrupt increases in the pulmonary vascular resistance and subsequently right ventricular pressures. Elevated right ventricular pressure causes increased right ventricular wall tension, cardiac muscle stretching, and right ventricular dilation. This increases the right ventricular myocardial oxygen demand and decreases the coronary artery perfusion, which causes supply-demand mismatch in the right ventricular ischemia. The consequent right ventricular dysfunction can lead to an inability to pump the blood through the pulmonary circulation, decreased venous return to the left atrium, decreased cardiac output, and potential hemodynamic collapse. Bedside echocardiogram can show bowing of the septum into the left ventricle due to the right ventricular pressure exceeding the left ventricular diastolic pressure, and right ventricular free wall hypokinesis with sparing of the apex. The presence of the right ventricular dysfunction along with the elevated brain natriuretic peptide and troponin level is associated with the increased mortality risk. It may be difficult to differentiate the pulmonary embolism from the right ventricular myocardial infarction, which can also cause right ventricular dysfunction. However, the right ventricular myocardial infarction is less likely to cause dyspnea or syncope and more likely to cause bradycardia or arrhythmias. The option alpha, that is acute mitral regurgitation, this is not the option of choice because acute mitral regurgitation can be complication of the MI and can result in the cardiogenic shock. Patient will have flash pulmonary edema and crackles on examination. The option beta, that is complete heart block, this is not the option of choice because complete heart block can cause elevated jugular venous pressure and hypotension. However, the bradycardia should be present. The option Charlie, that is left bundle branch block, this is not the option of choice because acute massive pulmonary embolism can cause right bundle branch block on the ECG. New onset left bundle branch block suggests acute MI. Dyspnea, hypoxia, and acute myocardial infarction is due to the pulmonary edema, which this patient does not have. The option delta, that was mediastinal widening. This is not the option of choice because mediastinal widening may be seen in the patients with aortic dissection. Patients typically present with a sudden onset tearing chest or back pain that may rapidly lead to the hemodynamic collapse due to the aortic rupture or cardiac tamponade. Dyspnea and marked hypoxia are uncommon. The choice eta, that is over here, the pericardial tamponade. This is not the option of choice because the malignant pericardial effusion can result in the pericardial tamponade. However, although pericardial metastasis is common in the lung cancer and lymphoma, it is rare in the colon cancer. In addition, tamponade can present with hypotension, but it would not cause dramatic hypoxia as in this patient. The choice gamma, that is tension pneumothorax. This is not the option of choice because tension pneumothorax can cause hypotension and elevated jugular venous pressure, but will not include decreased breath sounds in that hemithorax. This is usually seen in the patient on the mechanical ventilation or after suffering a chest trauma. So we'll keep this session till here and we'll continue with the question number 71 in the next session. Until then, Allah Hafiz, fi amanillah, and take care.